So now we're talking about lymphedema, and by definition, edema is abnormal. Edema means too much fluid in the interstitial spaces. We're on to pathological conditions now. And in lymphedema, the pathology, the edema, is caused by abnormalities of the lymphatic system. So there's abnormalities in the lymphatic drainage channels or in the lymph nodes. It's an edema caused by lymphatic pathology. There's an obstruction. There's excess tissue fluids. And as well as that, do you remember that some proteins leak out of the capillaries normally? So you get some proteins in the interstitial spaces. Normally, those proteins are drained away in the lymphatic drainage. But if the lymphatics are abnormal, as well as fluid being retained in those interstitial spaces, then plasma proteins such as albumin will also be retained. So it's also a high protein edema. So lymphedema, you get the excess fluid in the tissues, and it's a high protein edema as well. Well, where might we come across this? What parts of the body are likely to be affected? Well, the vast majority of cases of lymphedema affect the legs. Maybe 80% of cases are affecting the legs. That's what we see most commonly. But the arms can certainly be affected, especially if there's pathology or surgery or something involving the axillary lymph nodes. We see that. Genital edema is a possibility, where you get swollen scrotums or other swollen genital areas. And facial edema is possible as well, if it's the lymphatics which are draining the face. But the legs and arms are really the common ones that we tend to see. So how are we going to recognise this? What sort of clinical features are we looking out for? Well, very often this develops insidiously and slowly. And the first thing the patient might complain of is just a feeling of heaviness in the limb, even with no obvious swelling. It just doesn't feel quite right. But then over time, the swelling starts to develop. And initially, this is a pitting edema. So when you press your thumb into the edema and take your thumb away, there's a pit that's left. Now, later on, after several years, the edema will no longer be pitting. But in the initial instances, it's a pitting edema. And because the leg is full of fluid, very often you get skin creases. It's a bit like you're getting a baby. You get skin creases in the ankle and other skin creases as a result of the edema taking up a lot of space in the interstitial spaces. And because the edema is abnormal, the skin over the surface is not as healthy as it should normally be. The skin is compromised, the skin is embarrassed. So you can get different skin colour changes. Particularly, you can get a low-grade dermatitis. So it's not like an angry red like you would get with a cellulitis, but there's like a reddish colour. It's a low-grade and often very chronic dermatitis. Now, these patients can sometimes complain of pain because the edema can put pressure on the dermal nociceptors. So it makes sense that there is some pain. But mostly it's a feeling of discomfort, fullness, heaviness. Some patients describe a burning sort of sensation, and some patients do actually complain of frank pain as well. It does happen. And of course, because the limb is absolutely full of fluid, it's not going to bend properly. If you've got fluid over the joint's not going to work properly. So there's going to be reduced function. The joints are going to be compromised. Walking, biomechanical ability is going to be compromised. And if it's bad, we can call this elephantiasis. The legs can really swell up and almost look like an elephant's leg. That's why it's called elephantiasis. So, lymphatic abnormality. It's caused by lymphatic abnormality. That's what a lymphedema is. It's an edema caused by abnormality in the lymphatic system. There's obstruction in the lymphatic vessels or lymph nodes, excess tissue fluid, and it's a high protein edema. The affected areas, typically legs, arms, genitals and face. And clinical features we can look out for: heavy swollen limbs, pitting edema. When you put your thumb in, it leaves a pit, at least initially. Skin creases where there shouldn't be skin creases. Low-grade dermatitis is common. Pain, discomfort, burning type feeling, reduced function, and ongoing swelling of the limb. The swelling gets worse over time until you get a grossly swollen, distended limb. So we've mentioned that the onset of the condition is insidious. It develops over time. And the evolution is much the same. This condition evolves and gets worse over a period of time, possibly months or even years. There can be a more acute onset, but a very slow insidious development is the more common clinical picture. And the edema develops over time, and initially, as we've said, it's a pitting edema. And initially, it will usually reduce overnight. So the patient, when they get up in the morning, they've hardly got any edema at all, but then some can develop over the day. But then over time, because of the abnormality generated by the presence of the lymphatic fluid, the tissues become compromised and fibrous tissue starts to accumulate. There's depositions of fibrous tissue. There's a diffuse fibrosis. And this means that the leg, or whatever part of the body is affected, let's say it's a leg, starts feeling harder and firmer. And then in an established case of lymphedema, you're not going to get the pitting because of the fibrosis. It's almost as if there's a hard layer over the edema. The edema's still there, but you don't really feel it the same anymore. It feels hard without the pitting. And the fibrosis, because fibrous tissue has got a high tensile strength and it's not stretchy like normal skin, is you get loss of skin elasticity. Another common feature in lymphedema is that the skin becomes dry. These patients often have very dry skin. And chronic dermatitis. Not the infectious dermatitis that you might see, but chronic inflammation caused by the embarrassment of the dermis and the epidermis. But when we're looking after these patients, we have to have a high index of suspicion. So the evolution. Some people actually stage, they make up stages for this as well. But initially you get the progressive edema, which initially pits. Then you get hardening of the tissues. Then they won't pit. There's loss of skin elasticity. The skin is dry. And there's chronic dermatitis with colour changes. But the dermatitis that you get is not the angry, infectious dermatitis that you get in cellulitis. But we do have to have a high index of suspicion for infection in these patients, because infection and cellulitis are significant risk factors and we have to keep an eye open for them. And make no mistake, cellulitis is a spreading superficial infection and it is life-threatening. Patients with cellulitis, the area can spread. They'll get sepsis, severe sepsis, and possible septic shock. It's a life-threatening condition. And it's more likely to develop because the lymphatic drainage channels are fibrosed because of the long-term lymphedema. And the actual lymph nodes themselves can be fibrosed. So there's no habitat for the local leukocytes to live in. Normally the lymph nodes are full up of lymphocytes and macrophages and lots of other really helpful defence cells. But if the lymphatics are fibrosed, then those defences at best are going to be deficient. And as well as that, we mentioned that it's a high protein edema in lymphedema. So the fluid in the interstitial spaces contains a lot of albumin. And this is important because macrophages, which you might remember are the large phagocytic cells that can migrate through the tissues to phagocytose infecting bacteria, macrophages are unable to effectively migrate through high protein fluids. They like to migrate through normal tissue fluid, but if there's high protein, the proteins inhibit macrophage migration, and that means the macrophages can't really get to where they're needed to phagocytose the bacteria. So the bacteria think, well, this is great, and they go on multiplying without the presence of the macrophages. But it's a problem because it means that the person has got a regional immune compromise. They're more likely to get nasty cellulitis, more severe infections. And as well as that, because the regional lymphatics aren't working, the systemic effects of the infection can be delayed. So the patient might have the developing infection, but because it's not getting through the regional lymphatics, the signals aren't getting to the rest of the body, and the patient, they will start feeling ill, but it's going to take longer, so there can be a delayed inflammatory response. Again, indicating the importance of you making good local observations and detecting cellulitis at an early stage. We've noticed that the skin is dry, that's why we can just use simple moisturisers on these patients very often. And also they're prone to hyperkeratosis. Now, do you remember the name of the horny protein that's generated in epidermal cells? Well, in fact, we call them keratinocytes, don't we? The protein is called keratin. So normally on the surface of the skin, you have some keratin. The fingernails, for example, are virtually pure keratin. Hair is virtually pure keratin as well. But in lymphedema, there's a hyperkeratosis, and you can get brown layers of keratin stacked on the surface of the skin. And sometimes when you're dressing these limbs, lots of this hyperkeratosis can come off, which is good to get rid of it because it's not supposed to be there. And then papillomas can develop. Now, papillomas are like cobblestones, and they're made of fibrous tissue, but they actually develop as lymphangiomas. Fluid-filled lymphangiomas develop first, and then over time, because the fluid in the angioma is abnormal, over time the body tries to heal it, and there's fibrosis, so you end up with papillomas. These hard, raised, fibrous areas of fibrous tissue covered with normal skin. And lymphorrhea is another possibility. Now, I'm sure you've heard the term diarrhea. What does the rhea part mean? Well, rhea actually means to flow. So lymphorrhea would be flowing lymphatic fluid. So if the patients are injured, the skin's damaged, then the lymphedema can actually flow out of the surface of the skin, and you can see it leaking out of the surface of the skin. As the fluid collects, there's going to be shape distortion of the limb. The limbs aren't going to be their normal shape anymore. I suppose that's fairly obvious, really. And because of the immobility caused by the lymphedema, these patients are more prone to deep venous thrombosis, the pathology of venothromboembolism, because of the impaired movement. Another reason why we should keep these patients moving as much as we can. Well, it's quite hard to say how common this condition is, just what the prevalence is, but it's been estimated globally that there's probably about 500 million people suffer from this. So whatever country you're working in, you're probably going to come across patients with lymphedema. And in the UK, it's probably around about 2% of the population. So if anything, this condition is probably more prevalent than we think, and often is unreported or underreported. So complications. Infective complications can be life-threatening. Dry skin needs moisturised. Hyperkeratosis can be removed. Papillomas are raised areas of fibrous tissue that develop from lymphangiomas. Lymphorrhea is if there's any flow of the lymphatic fluid out of the body. Shape distortion means you can get very abnormal shaped limbs, and these patients are at increased risk from deep. And it's a relatively common condition throughout the world. Let's think now about the etiology of lymphedema. What causes it? And as usual, we can think about primary causes or secondary causes. So a primary cause could be genetic. There's genetic factors, but of course the genetic factors in most diseases, aren't there? You know, the etiology of most diseases is a combination of genetic and environmental factors. But what other primary factors can directly affect the lymphatics? Well, children can be born with something called Milroy's disease, which is an inborn disease of the lymphatic vessels. And you can get quite edematous children. Thankfully, we don't see this very often. And some areas of the body, people can actually be born with an aplasia. There's no lymphatics present at all, and they can get very severe lymphedema at an early stage. But more commonly, we see what you might call a hypoplasia, a lack of lymphatic tissue. So the lymphatics might function some of the time, but then lymphedema can develop later on. And these conditions are largely congenital. What does the term congenital mean? Well, congenital simply means present at birth. So the hypoplastic lack of lymphatics, the lack of lymphatic vessels, would be present at birth. But this doesn't mean to say that the lymphedema would present early in life. It could present earlier in life if it's severe, or it could present in childhood or adolescence, or even in later young adult life. So the fact that it's congenital doesn't mean to say it'll be there straight away. The evidence might not be seen for 10 years or 20 or more years into the patient's life. In addition to the primary causes, there are secondary causes of lymphedema as well. So any underlying condition that's going to affect the lymphatics or the lymph nodes can result in the development of lymphedema. So anything that causes fibrosis in the lymphatic drainage vessels or the lymph nodes can result in lymphedema. Now, I've mentioned that cellulitis can be a complication of lymphedema. Well, cellulitis is also a cause of lymphedema, especially if there's repeated infections. But even if there's not, just one episode of cellulitis, presumably what happens is that the bacteria release toxins, because that's what bacteria do. The bacteria release toxins. And these toxins get into the lymphatic drainage vessels and into the lymph nodes. And indeed, in cellulitis, the bacteria themselves get into the lymphatic drainage vessels and the lymph nodes. And in those vessels and in those nodes, the bacteria will release toxins. And these toxins can injure the wall of the lymphatic vessels, resulting in a fibrotic reaction. The damage can often be healed by fibrosis. So even a single episode of cellulitis can result in lymphatic vessel and lymph node fibrosis and subsequent lymphedema. As well as that, repeated infections are going to increase the probability that lymphedema is going to develop. So, high index of suspicion required for cellulitis. Early antibiotic treatment means there's less bacteria, less bacterial toxins, and then hopefully less fibrotic reactions, making the development of lymphedema less likely. So cellulitis. Chronic edema itself is another cause. So if someone's got chronic venous hypertension, resulting in venous edema, the abnormality there again can lead on to the development of secondary lymphedema. Obesity is a risk factor. Obese people are more likely to develop lymphedema than thinner people. Presumably what happens is the fat is pressing on the lymphatic vessels all over the body, wherever the fat is, resulting in reduced lymphatic drainage and again the development of chronic fibrosis over time. Cancer is always a possibility, of course. So tumours can press on lymphatic vessels, occluding them, resulting in the development of a more acute, possibly, lymphedema. Then lymphatic malignancy itself can happen, so tumours can actually grow within the lymphatic vessels as well. Very often as they're metastasising, as they spread, there can be secondary growth of tumour within the lymphatics and within the lymph nodes. And then there's quite a few iatrogenic causes of lymphedema as well. Causes where the lymphedema is actually caused by some medical treatment. For example, radiotherapy in malignancy. the radiation can damage the lymphatics. Or nodectomy, surgical removal of lymph nodes, means that there's not enough lymph nodes left to provide lymph drainage of the limb or wherever the lymph nodes have been removed from. Other times I've seen this as surgical trauma. For example, after knee surgery, the lymphatics can be inadvertently damaged during the surgery. And again, the lymphedema might not present straight away. It could present a year later or 2 years later after the surgery because of damage of the lymphatics during surgery, surgical trauma. Filariasis is a tropical infection where you get parasites growing inside the lymph nodes, blocking them off. And that can be treated with drugs. But of course, edema can have a mixed etiology as well. So there could be a venous component to the edema and a superimposed lymphatic component to the edema in addition. So there can be mixed etiology as well. It doesn't have to be pure lymphedema. So we need to assess these patients so we can make a diagnosis. Now in pure lymphedema, you're going to have the swelling without the clinical features of other causes of edema. So in a sense, it's a bit of a diagnosis of exclusion, that you get the swelling, but there's not another identifiable cause of the edema. For example, there's no kidney disease, or there's not heart disease which is causing it, or it's not caused by chronic venous hypertension and venous insufficiency, where you get the brown staining which is called hemosiderosis. So a lot of it is your own clinical judgment of the edema that you're examining. But of course, as always, we want to take a history. Is there a history of trauma? Is there a history of surgery? Is there a history of previous injuries? What is the patient's history? Anything that might guide us towards the diagnosis. And if at all possible, we want to work out what the cause is. What is the particular cause in this patient? If we can work that out, that's good. We certainly want to know if there's any cancer present, so that can be excluded or treated if necessary. We want to know if there's any vascular disease. Is there arterial insufficiency? Is there venous insufficiency? And we're going to see this later on, but it makes a big difference as to whether it's affecting one leg or two legs, or one arm or two arms. So is it unilateral or is it bilateral pathology? And in fact, this is true whenever you're looking at hands or legs. You should always look at both of them together. Then you can see whether one's normal and one's abnormal. And if that's the case, you can compare the two. Always compare both limbs, one with the other. We can look at limb circumference. The limb can be measured in various areas to see what the circumference is. That can help us chart the progress of the disease and chart the progress of therapy as well. And if you want to be sophisticated, you can do limb volume tests, where the limb would be immersed in fluid and you would measure the volume of fluid which was displaced to assess the volume of the lymphedema. So differential diagnosis really means, well, what else could this be? What are the other possible causes? And first of all, I want to think about the differential diagnosis in bilateral lower limb swelling, if it affects both legs. Well, it could be chronic venous hypertension. That can affect both legs, but actually that can affect just one leg as well. So quite often in chronic venous hypertension, you might have one swollen leg and one not. So that one could actually go into either category. But right heart failure, congestive cardiac failure, can cause bilateral lower limb edema. Now we normally call this congestive cardiac failure, but actually it's the right ventricular failure that's going to lead to the systemic edema. Because if you think about it, the systemic veins are going to drain into the inferior vena cava, that drains into the right atrium, and that drains into the right ventricle. So if the right ventricle is not pumping properly, the blood's not getting out from the right ventricle, there's going to be a backlog. into the systemic veins, and that can lead to bilateral lower limb edema. Renal failure is another possible cause. If a patient's in renal failure, they're not producing enough urine, they're not getting rid of the fluid, and the body can become quite edematous in renal failure. And then liver failure can also cause edema. Now how does liver failure lead to edema? What's the thinking here? Well, if the liver's not working properly, the liver is unable to make the plasma proteins, because it's the liver that makes the plasma proteins, primarily the albumin, that increases the osmolarity of the plasma and allows the reabsorption of tissue fluid at the venous end of the capillaries. So in liver failure, there can be a hypoproteinemia, and that hypoproteinemia can lead to bilateral edema as well. And indeed, any cause of hypoproteinemia can lead to edema. Nephrotic syndrome, where a lot of the protein is simply leaking out in the urine. Or malnutrition, if someone's not getting enough protein to eat, can cause hypoproteinemia with consequent edema. And limb dependency is another possibility. This just means that the legs are down all the time, and the dependency just means that the fluid accumulation is dependent on gravity and it settles down. You get this in immobile patients who might be sitting there all day, especially elderly patients who are immobile, and they develop this limb dependency edema. But it's always worth thinking of other causes of edema as well. Allergy, for example, can cause bilateral edema. Infection, not such a good example, that would tend to be unilateral really, but allergy can cause edema all over, that's possible. And then one other condition I want to mention is lipedema. Now, the lip part is well named because it's lipid, it's a fat condition, but the edema part is not, because it's not a fluid. And in lipedema, what you actually get is abnormal distribution of adipocytes. And patients can get very fat legs, even though the rest of them might be quite thin, they can get very fat legs, but it's not caused by edema, it's actually caused by fat. And sometimes called painful fat syndrome. It can be a very unpleasant condition for these patients, and it's called lipedema, not really edema, but that's the name we're stuck with. So, bilateral causes. Chronic venous hypertension, as we've said, can be bilateral or just one-sided. Right heart failure will be bilateral. Renal failure will be bilateral. Liver failure and hypoproteinemia will be bilateral. Limb dependency, nearly always bilateral. Allergic will be bilateral. Infection probably less so, because it might just affect one leg. And lipedema with abnormal distribution of fat. This is not lymphedema. The swelling is caused by fat, not by fluid. So still thinking about differential diagnosis, what else could it be if it was unilateral, just affecting one side? Well, it could be a complication of cancer with tumours pressing on the lymphatic vessels, or it could be a complication of our attempts to treat cancer, either with nodectomy or radiotherapy. DVT, it could be a deep venous thrombosis affecting one leg and not the other. Chronic venous hypertension, as we've said, can affect both legs, but usually it's worse than in one leg than the other. So chronic venous hypertension really should go under the unilateral side. And arthritis, well again this can be bilateral, but if there's arthritis, it's very often worse in one knee or one hip. And that's going to reduce the mobility of that limb, and if you reduce the mobility, you reduce the venous and the lymphatic return, because you don't have the benefit of the muscle pumps and the general mobility, which is improving return of blood and lymphatic fluid from the periphery. Well, unfortunately, there's no cure for lymphedema as such. So what we're normally left in is a chronic management position. These patients need managed over many years. And the first thing to mention is that skin care is very important. Simple cleaning of the skin, keep the skin clean, But then because the skin is prone to drying out, just use normal moisturising creams to keep the skin moist. So regular skin cleaning followed by moisturisers is very important. We want to prevent skin and tissue changes. Now, if it's not treated, over time lymphedema will give rise to many skin and tissue changes. We want to prevent these. And we prevent these by reducing the amount of edema. We need to reduce the amount of excess fluid in the tissue spaces. If we do that, keep the patient well managed, then we'll prevent many of the long-term complications. So early recognition, early management, prevent the complications. That's the crux of the management in lymphedema. So how are we going to reduce the amount of fluid in the limb? Well, we're going to use decompressive therapies. We're going to apply compression, and we can do that with bandaging, or some people use pneumatic compression. I've never done this myself, but they actually blow things up round about it to help squeeze the fluid out of the limb back into the systemic lymphatics. So short stretch multi-layer bandaging is the normal approach we would use. And we want a graduated pressure. So the pressure's higher in the ankle, gets lower as it goes up the leg, but that means there's going to be a higher pressure in the ankle to push the fluid back up towards the systemic lymphatics. We want a graduated pressure profile up the leg. But we also need to bandage the toes, because if we don't, if we start the bandaging at the foot, then we'll get little sausage toes, the toes will fill up with fluid. So we need to bandage the toes and the rest of the limb. And then once we've got the size of the limb down to a reasonable volume, we can just use compression hosiery. And in fact, if you pick these patients up at an early stage, we can just use compression hosiery, and hopefully that will stop the condition developing. But many of the patients I've seen have had established lymphedema. They need bandage compression therapy to get the edema down, but then once the edema is down, we can hopefully maintain it with regular use of compression hosiery. Exercise, of course, is very important. Normal limb movements, normal exercise is going to increase lymphatic drainage. Now, I know that the lymphatic vessels are contractile themselves, but of course adjacent muscle movement is going to massively increase lymphatic return. So mobility and exercise and movement is absolutely pivotal. Deep breathing actually helps as well. Deep breathing is going to generate negative pressures in the chest and help suck the lymphatic fluid through the thoracic ducts. So even in a bedbound patient, they can do deep breathing exercises from time to time. And as well as helping lymphatic drainage, as you probably know, that will also help venous drainage as well. Now, manual lymphatic drainage massage can be used to move the fluid from where there's no lymphatics to drain the fluid into other areas of the body, so the fluid can be drained in sort of collateral lymphatics or other lymphatic vessels. So sometimes just manual massage to move fluid from one part of the body to another, just very gently. And that means that other lymphatic vessels can take over the job of the damaged lymphatic vessels. Manual lymphatic drainage. High index of suspicion for infections, very important, remember that. And treat infections at an early stage. The earlier you can treat the infections, the better. Flavonoids, there's some research that shows flavonoids is good, but you don't really need me to tell you that fruit and vegetables are good for virtually everyone. Make sure all our patients get plenty of fruit and vegetables. Then they'll get all these essential vitamins, nutrients, flavonoids required to maintain healthy tissues. And then if someone has got the filariasis parasitic infection, there are drug protocol treatments available for that.